Yracheta from Missouri Breaks International Industries Research Incorporated in Eagle Butte, South Dakota, where his wife and kids are enrolled Lakota members. He graduated from Loyola thank you, University of Chicago with a BS in psychology and minor in biology, and from the University of Washington, Seattle, and master's, is that where he graduated with his master's in pharmaceutics. He's been a biomedical technician for 16 years in fields very diverse, spanning neuroendocrinology, drug abuse, cardiovascular endocrinology, renal function, kidney transplant, and immunology. His interests lie in closing the health disparities gap for Native Americans and indigenous peoples from all the Western Hemisphere. He's helping to educate and empower Native groups to make genomics as a tool that they use at their own discretion and benefit. And we were blessed a few months ago at Stanford Research to have Joe come and spend the day with us and give a presentation. And just to hear his passion for genetics research is truly inspiring. Welcome, Joe Yracheta.
I wanted to thank CRCAIH and MBI, RI, and Lyle Best for allowing me to piggyback on the study he initiated. So for the sake of time, I'll try to go through some of these slides pretty quickly. As I am married into the Yracheta tribe, I wanted to greet you. Chante Washtea na pe chiozalablo. Tate Kichinaji Amache below. Jesus Yracheta Tunkarshla na Eladio Duran Unchi way. And then in my own language, I'm Mexican of indigenous descent. I'm from a tribe called the Yracheta. Tata Yracheta Kanana Echere Simarani Haru Parani Hatsiki Ka Hesi Hamashaka Ini Huretekwa Imbo Hi Urabecheska Ka Uchete Tatecha Arina Quat Sinti Maria Ka Manueli Hi Arina Shin Tanashwan. So both of those greetings are basically saying I'm glad to be here today, and I offer my warm heart and a glad handshake, and my parents are Manuel and Mary. Just briefly about me, the Yracheta, and I'm also Radamuri, which is the Tarahumara, the ones that run barefoot, those long distance races. So the Yracheta are on the left here. They come from central West Mexico, and the Tarahumara are from Copper Canyon, which is just south of the Grand Canyon, which is a much bigger canyon. This is Missouri Breaks and the Strong Heart Study. I just joined with them at the beginning of the year this year, and Lyle and I have had a relationship for another year prior to that, and he and I have become fast friends. So these are some of the statistics that Lyle has already gone over with you about the prevalence of asthma in American Indians. And then here are these slides. I wanted to just talk a little bit about different studies that go over exactly where the difference is as far as genetics are concerned with Native American asthma. So part of the problem is that in the literature, Native American describes everybody from Alaska to the tip of South America, so that's problematic, especially for clinicians that have to do some really quick reading and might not get into the subtleties of some of these things. So these studies are done by Carlos Bustamante and Esteban Burkhardt, which are both in California, one at the University of California, San Francisco, the other one at Stanford. And their studies have shown that actually the Native American portion of admixture in Latinos is actually protective against asthma, and African American admixture increases your susceptibility to asthma in Latino populations. There's two parts of that for African Americans or African American admixture. One is that they respond less well to inhaled steroids and bronchodilators, and the other thing is something that Lyle referred to already in regard to this hygiene hypothesis. And so Cubans and Puerto Ricans who had higher social status had higher degrees of asthma. The ones that had lower social status had lower or no asthma at all. And so the idea is that the ones with the lower social status had more exposure as children, whereas the ones that had higher social status had a much more cleaner childhood environment. So that might be the reason. And this is a different study done by the CDC, where they did a meta-analysis of American Indians and Alaska Natives for various inflammatory conditions. Asthma, hay fever, sinusitis, and COPD is not truly a inflammatory or an allergic inflammatory condition, but it's an autoimmune condition. And they show that that the groups separated. If you are European American or Native American, had low levels of responsiveness to these conditions, but the admixed children had more responsiveness. Of course, there's caution when interpreting this data as a meta-analysis, and there's all kinds of reasons to question data like this. But the reason why I bring it up is because as my introduction stated, I'm trying to sort out all these different variables of whether they're social context, whether environmental context, or whether they're truly genetic context of what makes people susceptible to certain conditions or not. And then this is the methods and participants that Lyle had already gone over. So my portion of the analysis was to look at BMI and asthma. And we wanted to validate that indeed, similar to other populations, that BMI was associated with asthma in American Indians as it is with other pediatric cases with asthma, which are similar to the statistics that Lyle already presented. The other thing I wanted to do is analyze nicotine or cotinine exposure for these children for cases and controls. And as you can see, that almost everybody had exposure to nicotine at some point. 84% were exposed, 70% were in the 10 to 30 nanogram per milliliter range. The higher cotinine exposures were found in the controls, which was kind of unexpected for us. And then the controls with higher cotinine exposures also had higher BMIs, and Lyle and I discussed that a bit. So we explained that possibly due to socioeconomic factors and modifications of behavior. So if you are a parent with a child with asthma, you're probably going to smoke less. So that might explain why the children who are in the control group had higher exposures to cotinine or nicotine or tobacco exposure. And then within the control group, those with lower socioeconomic status in other studies have been shown to have higher BMI. So that's how we're looking at that. And then we also looked at an analysis of these factors in steroid use, and we found no difference. And with steroid use, we usually see higher BMI, especially with prednisone, and we didn't seem to find an association there either. And so, coupled with the session that just happened before this with the pilot project, with the validation of instruments, the data collection methods, different aspects that happen within the hospital care context, either in the patient exam room or follow-up. I think that previous session really informs this one, and that data capture in this population is unique and very different, and explaining those contexts not only to federal funding agencies but to other researchers in the community would be one of the more important factors of the research that we're doing. So what we found out with from anecdotal and observational information that I got from the recruiters and the nurse researchers is that it's really hard to do any kind of exposure analysis for tobacco with these children because they move within a week. They move from between 2 to 5 houses in a week, and there's a lot of reasons for that. Sometimes it's school, sometimes it's jobs, sometimes it's home violence, those kinds of things. So if you ask the parent about their child's exposure and they self-report that there's very little exposure, that data can be skewed by the actual moving around, because at the other different houses you didn't get that information. They might be exposed in those other places. The other thing that came out of this was that the health literacy, which was also addressed in the previous session, is low in this community, and so they were finding that when they were asking parents about tobacco exposure, some of the parents thought that tobacco exposure meant that they just went into another room and closed the door. And tobacco is really, I don't know what you call it, ephemeral. It really gets into every space, and even when you're done smoking, it's in the carpeting, it's in the drapery, it's on the walls. So it's really hard to get that part of the data capture in there. A lot of times, the parents, if they didn't close the door, they would smoke with the window open and blow the smoke out the window, or smoke with the screen door open and blow the smoke out the screen door, which is also really an exposure, but was counted as not being exposed. And all of these issues are tremendously important because, as I stated in the last session, we have this kind of vicious cycle of a lot of research and not really a big change in outcome. And part of that might be driven by inappropriate measurement instruments, pretty much inappropriate data capture, and then lack of real public health intervention. And so the last session and the points that I'm making now is we have to try and break that cycle and validate instruments within this community. A lot of times they're not. Just one example is the mental health locus of control, which I looked up and has been validated in the deaf community, in a Latino community, African American community. It's been validated in even a Malaysian community, but I could not find a reference in the literature that was validated in the American Indian community. So there's lots of cases like this. If you don't do it the right way and do the data capture, you're not going to really significantly impact the outcome. And as Lyle mentioned several times, the nurse researchers at Missouri Breaks went to really heroic efforts to vet these records, and we found a lot of errors in the medical records, and they caught all of those. And I can't remember the statistics, but it was really shocking to find out how inaccurate some of these were. Some children were diagnosed with asthma just because they got prescribed an inhaler one time, and then I think there was about 100 that went undiagnosed, but the nurse researchers had captured those because they made phone calls and made the right inquiries about those children. So they really deserve a lot of credit for the vigorous and rigor of this particular study, which would not be captured in any other way. And again, with the funding agencies, we have to convince them that these are the cases, especially in terms of medical records that are often kind of foundering in a basement somewhere, that need to be reorganized and salvaged and then digitized so that they can be used in research. And with that, there's the acknowledgement, same as Lyle's. Thank you very much.